Thank you for coming again, Dr. Lee Coleman. I want to finish up this group of sessions taking off from where we ended up, where basically we focus on the fact that psychiatry is not diagnosing anybody. It's merely summarizing symptoms, summarizing what people feel, what their behavior is like, and those are serious problems. We're not minimizing anything. But what we're saying, it's not medical. Psychiatry is practicing a kind of pseudo-medicine, and it's doing it for financial and prestige reasons. I want to focus this time on what psychiatry would be doing if it weren't doing that. If, there's no quarrel if some people want to specialize in studying the function of the brain in the hope that pathophysiology, neurological and or chemical circuit type of disorders and discover mental disorders of that type. If they want to try to do it, I'm not arguing they shouldn't be allowed to do it. But in my opinion, I don't think it will ever touch on the heart of what mental problems, emotional problems, problems of our mind and our being, the kinds of things that psychiatry deals with: self-esteem, depression, thinking, behavioral problems, so forth. I don't think medical diseases will ever touch on it, but other people might have a different opinion. The main point is they don't have it now, and they need to stop claiming that they do, and therefore they need to stop claiming that their drugs and other physical treatments like shock treatment are treating diseases, because the evidence is clear that that's not happening. Okay, if that were true, what would we be left with? We'd be left with what was the major focus when I was in training and used to be the major focus of psychiatry, that is the patient's presentation or symptoms. That can be what the patient complained of, like in medicine in general, or what other people were noticing. Maybe the person isn't complaining of anything, but they're a real pain in the neck to people around them, or maybe they're scary, or so forth and so on. And those problems are real just because they're not medical. Who says a problem has to be medical to be real? So we will be left with a psychiatry which is dealing with problems which we will call symptoms: behavioral problems, emotional pain, and so forth. Now, the biological people, the people so ill-advisedly promoting this as though it was an accomplished fact when it isn't, they desperately want to move beyond symptoms into diagnosis, which is cause. So desperate that they have a diagnostic manual getting thicker and thicker every decade, which is nothing more than symptoms, but they still call it a diagnostic manual. So they desperately want to find those medical causes, but if we just recognize that that's all we have, and then I ask you, who's to say that would be better off if we didn't just stick with symptoms? And I want to argue with it, given that's all we have, aren't we going to be better off by admitting what we have and then working with that? Now, when you're a medical doctor who is practicing real medicine, like an internist, surgeons, radiologists, cardiologists, pediatricians, and so forth, scientifically determinable medical disorders, where you not only identify the cause, but you have treatments which are designed to address the cause, maybe some better in some conditions than others. And you can then measure to what extent are those treatments addressing the cause. When you have psychiatry only dealing with symptoms, let's compare what it's like. I'll call it real medicine, and then I'll call it phony medicine. That's psychiatry. In real medicine, you do want to take a narrow view. if I go to the dermatologist, which I do regularly, fair-skinned, and the dermatologist is looking to see whether I have a possible melanoma, he's not interested in much about my life. Why should he be, or she? They want to know. And so they have a biopsy, and they take a piece of it, they look, they send it to the pathology laboratory, and they can tell in a reliable way whether there are features there which are dangerous, or whether it's already a melanoma. That's already happened to me. But I got them early enough because I go. Okay. That's real medicine. That's science. Symptom was I noticed something and they see something. They send it for evaluation and then treatment. In psychiatry, rather than being dissatisfied with dealing with symptoms, we are interested in symptoms. We broaden our view. We don't narrow down our view. And why is that? Because with real medical diseases, you have a close correspondence often between the symptom and the cause. Not 100%. That's why we need testing, various kinds of laboratory procedures, radiological and other methodology. The symptom doesn't automatically tell you the cause, but there's more likelihood that there is a direct connection between the symptoms and the cause. But in psychiatry, it doesn't work that way. Symptoms can come from all kinds of causes. When you start trying to go from a symptom to a cause, that's what psychiatry is doing now, thinking, well, we'll even call that a diagnosis, which is ridiculous. So you don't want to narrow your view in psychiatry, you want to broaden your view. How are you going to broaden your view unless you spend time getting to learn about the patient? The narrow view of the dermatologist or the internist or the pediatrician to find the cause, what we need in psychiatry is just the opposite. We want to go from the presenting problem that the patient has and then investigate, because we know there are so many things that can cause those same symptoms. And if we're going to investigate, why should psychiatrists be the leaders of the profession? There's no reason for that. We have psychologists, some of them PhD psychologists. We have a lot of different kinds of counselors, social workers. And who's to say that psychiatrists are smarter than psychologists? And those two are smarter than a master's in social work. What a bunch of nonsense is that? Talent comes wherever you find it. There's many reasons why people end up in the professions they're in. And the idea that the psychiatrist would know better than the next level down is completely ridiculous. Talent comes in those who have it and those who work for it. So we need a psychiatry where we investigate symptoms and not be afraid of it. Quit creating these phony diseases that don't exist. Now, this investigation can come in many forms. It can come in talking to people. That's the kind that I practice, but that doesn't mean what I did may make little difference to somebody who's in the middle of an acute psychotic breakdown. You can't talk to them then. You can't do that. You can try, but they're just not ready for it. But they may have been ready when the psychotic breakdown was beginning. And what do you think will allow you to talk to them sooner rather than later? Mental investigators who work in different kind of facilities but can't force things on them. That's what brings people in sooner rather than later. If you were here when I talked about shock treatment, they talked about people not responding to drugs, but they never said what else they might have been trying to help these people with this depression. They didn't once mention anything about helping them in any other way except that they were put on 20 or 30 drugs in the case of Kitty Dukakis. So we need investigators from medicine. Sometimes that's important. People get put on medications legitimately by internists and so forth. Maybe a medication is causing a side effect. We need non-medical investigators. Sometimes it involves in helping a person get work, social support. That's the kind of psychiatry that I decided I wanted to go into. That's not where psychiatry has gone. We have a lot to do. Come back with your questions, your comments. See me next time. I'll look forward to it, and thanks for coming.